And thankfully, we still have about 10, 12 minutes for discussion. So I'm going to stop sharing. And, people can turn on their cameras and we will open it for any comments, discussion, and, suggestions. And Alex, are there any questions from the audience?
Yeah, after Dr. Edelman's talk, there was one question that was placed into the chat box, just asking about tension banding, in particular for posterior medial bowing of the tibia, and if there's any role that's currently being utilized.
All right. Mark, are you there? Does anybody else in the panel want to answer that? The Mark Dahl technique of anterolateral hemiepiphysiodesis is instrumented for infants with anterolateral bow, mostly neurofibromatosis. I mean, I've had very limited experience, N of 1, where actually the plate migrated proximally, but I'm going to redo the fixation. But I think from what I recall, Mark's paper suggested it's best done, in early childhood, real early childhood. I forget the numbers, but what was it? Maybe others remember, like
Sanjay.
2 or 3 was, yeah, go ahead, Mark, go for it.
Sanjay, I lost the connection. What was the question?
Oh, you talked about McFarland, and you had mentioned the distal hemiepiphysiodesis.
Yes.
That Mark Dahl talked about. So I think somebody was asking in the audience, any experience with that, any pitfalls, etc.?
Well, I have limited experience, but at least what Mark Dahl presented, it's worth to do, maybe. Yeah. Because in all his children there was no fractures, and as he said, even if finally will be fracture, it's delayed time for cross union, and it's really minimal invasive procedure. It's not cross union and not McFarland. I think it's worth to do. Yes.
Is there an upper age, and if anybody else wants to chime in, is there an upper age to do that procedure after which you're like, it's really not going to work?
I think that Mark Dahl do it only lateral hemiphysiodesis, but I think it's worth to do what was published in Lane paper, approximately medial hemiphysiodesis and distal lateral hemiphysiodesis, because in this way you correct both deformities of congenital anterolateral bowing.
Okay, great. Tony has his hand up.
Please.
Yeah. Tony?
I've got a little bit of experience with this as well. So I've done a few patients, and Sanjeev, I had the same issue with you in that when they're really little, you can't fit an 8-plate or PD plate in there. So I've used the Minifragger 2.7 screws, and they do cut out, and then you have to redo them, and I've redone them, and they've had no permanent growth rest from that. And then I think that you have to take each proximal one kind of on a case-by-case basis. Some of them have a really significant deformity proximally, and some of them have less so. So, and when you think about the growth discrepancy between the proximal and distal tibia, you just have to counsel the family that it might be taking out one earlier than the other. But I think that in terms of age, I don't think there's an upper age restriction. I think that it definitely slows and reverses the deformity in these kids, which you'd otherwise be watching and bracing and then inevitably intervening, or they fracture and then intervene. So I think it definitely changes the natural history of these. And I think there was also a question about posteromedial bowing. So I've got a couple of cases of posteromedial bowing that I've done the same in, where they haven't corrected kind of naturally on their own around about age 7 or age 8. But I found that they grow very slowly. You have to be very careful about where you put it at the apex of deformity there. But then I find that they grow very slowly. So I have one that's been going for about 18 months with minimal correction from that.
Great, thanks, Tony. On a couple of the previous speaker slides, there was this whole issue of guided growth, and I think it is a toss-up, right? It's so tempting and attractive to do a minimally invasive same-day procedure. But like most of us have had the experience, once in a while, patient doesn't show up, and oh my God, then you've created a bigger iatrogenic problem. So I think it was well illustrated But the question is, how do you choose patients, especially for, some of our overseas, from our surgeons who've had global experience, what do you do in those situations? Do you just, like, like Norgrove was saying, still do a bigger operation and do an osteotomy versus do guided growth? So is there any sort of magic test that you can do, or it's just a gut feel?
I think the issue there is, can you get follow-up? Can you be assured of it? And what we're seeing in even very low-income countries like Uganda is a growing middle class. I would say about 20% of the country is middle class. And, this whole issue of money, if we're training these surgeons to go back to their home countries, how are they going to earn a living? They're probably not going to earn it taking care of the rural poor, unfortunately. They're going to earn it off the middle class. So they need to be able to do that and provide that. And in those people in Uganda, it's exactly the same as it would be in Canada or anywhere else. You can rely on them to come back for follow-up to do their clinic appointments. They tend to be urban, so that they're in the city. Transport isn't a problem. So I think this issue of guided growth has to do with the rural poor. And if you look, every study I know examining the impact of poverty on medical care, the number one problem people have is transportation. They can't even afford the transport to get to the city. So I think now you have to have a strategy for them. Now, I'll just tell you, there's something that is never talked about that I was exposed to in Africa called community-based rehabilitation. It's not as strong as it used to be, but in India now it's really coming in as part of the National Health Program. And that is that you have community workers in the community creating awareness. And if you can develop your surgical program in coordination with community-based rehab, where those workers know. And a really interesting thing that we've used now is smartphones with GPS. So people in villages who don't have a fixed address, well, you can get their GPS number. And now you have village workers who follow them up. So I think there may be creative solutions. It's just you have to know it's there. And if it's not there, then you have to be really careful about guided growth, as seductive as it is. And that's where, okay, doing a simple osteotomy in a 4-year-old and pins and plaster, they recover very quickly, and you haven't got that worry. So that's what I think I was trying to bring up in that particular component of the talk.
Yeah, and Mika or Scott, any other thoughts or differences?
Yes, I think Norgrove's experience is really pertinent. It explains the scenario that I'm in here as well. Most recently, over the last couple of years, I start maintaining my reminders list on my phone. And every time we do an 8-plate case here, I program a 3-month or a 4-month reminder for them to come back. But even then, it's, I have the reminders. I have to check in clinic. There's lots of responsibility. There's lots of things going on. We currently have a situation also where we have some community health workers that are working with another organization, and these people are super reliable, and they understand the differences between a big operation and an 8-plate, and have committed themselves to bringing these patients back. And most of the time they're very good. But 2 weeks ago, they called me and they said the parents of one of the children that we put 8 plates in is absolutely refusing to come to Port-au-Prince. There's gunfire all around us here right now, and I can't really blame them for that, but I don't know what to do about this situation. I mean, it's an 8-plate disaster in progress right now, and I can't get them back to the hospital. And so when in doubt, I'm just doing a bigger operation, because there's nothing wrong with big operations and we know how to do them. And the satisfaction that these parents get from an immediate result is great. And I've never had any of the sometimes I felt guilty for putting on an external fixator, doing an acute surgery, knowing how much bigger of an operation this is, but everybody is universally happy after seeing that.
Oh, good point. Very counterintuitive, but true. All right. Any last minute thoughts, questions? We're like a minute away from break.
Okay, let me just, in my own perspective, I usually don't do 8 plates anymore for very young children. I use them for more or less adolescents with adolescent onset Blount's disease, because they are more aware and they can actually force their parents to bring them to the hospital for follow-up. Because when the patients are more aware, I tend to talk to them personally, one-to-one, that look, this is what's going to happen if you don't come to the hospital. But in little kids, you can't trust the parents to bring them. So I just do a simple bigger operation, a simple osteotomy, which with the cars, they'll definitely come for that, and they'll come to remove it. And so that one, but when something is hidden in, they believe if you don't come, it doesn't really matter until it gets too late. So that's the experience I have in Nigeria.
Great. Thank you so much. I think we're going to break for lunch, and we'll be back at noon. So that's about 40 minutes or less from now. And I'm really looking forward to the next session. It's going to be a potpourri of a lot of interesting cases. And I think my challenge is going to be to go through all of these great cases and still get in some discussion. So we'll try our best. We're going to just run it through my computer. And I think it's going to be a great session. So we'll see you all in about 30, 35 minutes. All right. Thanks again.